Thank you. Good afternoon. We're really delighted to be here. I'm going to be starting off the talk, and then Laura will be taking over. It's really nice to have a chance to do this. One of the things we miss the most in Eldoret is having these opportunities to kind of be students again and learn. And as you can tell, I spent a lot of time in school up until very recently, and so it's always fun to be in a classroom again. So thankfully, Cynthia gave us a really nice introduction about ourselves, but also about AMPAC, the program. And so most of what we're going to be presenting today is about one of our interventions that has come about through this collaboration. If you have any questions during the presentation, please interrupt, or if you feel like I don't really understand how this works within this larger idea of universities working together to improve health of citizens, we have lots of opportunities to stop and take questions. So really what I want us to start off and have you guys think about is, I want you to think of who you turn to when things are difficult. When times are tough, when money is tight, who is it that you look to for support? Is it your family? Is it your friends? Who is your community that you look to? What we found in working with the primary healthcare program in Eldoret, in Western Kenya, is that most of the time when women were facing a ton of adversity within the home, dealing with poverty, dealing with a lot of violence, that most of the time they had no one to really turn to for support. This idea that African women are always together and united was one reality that just did not bear out when we actually went to the field. And what we did find in looking at how women do adapt when things are difficult is that they rely on something called a chama. A chama is kind of what you look for, is exactly what you want when times are tough. It's a group of people. In different settings, it's thought of either as a religious group. In Tanzania, it's thought more of as a political group. It's this idea that when you're grouped together, a lot of things can happen and you have a lot more power and resources at your disposal. So using this idea of groups, we decided to see how they could be useful to us in advancing maternal, newborn, and child health as part of a larger primary health care partnership in Western Kenya. So today, that's what we're going to be talking about. So our objectives is to get us thinking a little bit about community as we think about maternal, newborn, child health, how this has become part of our strategy within AMPAC, within maternal, newborn health, and as we widen our gaze, we see that within chronic disease and other partners that we have looking to see how we can deliver better care within the community and using these resources. We're going to talk a little bit about how we've tried to think about accountability and peer support in our own theory of change within maternal, newborn, child health. Laura will then present about how we've used Chamas as a platform for service delivery. And what we'd love to get your, pool talent in this room is looking at how we might be able to use the Chamas in different ways as a service delivery platform. So when we talk about community, it can look very different in the areas where we support the government and primary health care. And so our engine of change is really the university, and using Moi University as a way to scale up talent, to scale up ideas, and to scale up care. And so this is the Rift Valley, which is just north of Eldoret, and as you go a little bit more west, you're completely surrounded by maize and greenery. And a key feature of any travel in this part of the country is the mud that we have to deal with. Where the edges of our catchment area goes along the borders of Lake Victoria, and where this particular intervention took place was along Lake Victoria in a district called Bunyala. And in order to get to some of the villages or areas where we do support the government in primary healthcare activities, this would be one day's journey to try and get to reach them. In the areas where we do tend to visit communities, what you do find are a lot of children alone having to care for themselves, and women having to spend a lot of time outside the home taking care of water, getting other resources like wood, and making sure that They can sell whatever goods they have on the market. It's been a place where community health workers have been identified as being able to play a key role in trying to provide some advocacy. And our community health workers, of which one is right here, is using a phone to try and see how the child is actually doing within the home. As we know well, especially here at Duke, women bear the burden of doing most of the cooking, which happens indoors in really toxic, if not criminal environments. And from a very young age, girls learn the heaviness of being a woman in this environment. So it's with that community in mind that we are actually a much larger community within AMPATH, and this includes most of the, or all of the universities, as well as the Kenyan government, Moi University and the MTRH, who are in this really awesome collaboration together called AMPATH. And of course, it's important to remember we also have industry partners that support the collaboration as well. So when you think of the problem that we face within primary health care as it pertains to maternal newborn child health, a lot of this is going to look very similar to you, to many different contexts in which some of you guys might work or be coming from. And so within Kenya, like many places, a very high number of women go to at least one prenatal care visit. So according to the last DHS survey in 2008, it was about 92%. But actually only half of women do the recommended number of ANC visits, which is 4 within our setting. Any idea how many visits a typical pregnant woman would do here in North Carolina who had insurance?
12.
What's that?
10, 12.
Yeah, I think the average is about 10 to 12. What you do see is that although almost all pregnant women will have some contact with the facility, only half of them, if not less, will actually choose to deliver in the facilities. And a home visit within 48 hours, which time and time again has been proven to be a very effective way to identify early emergencies or complications related to childbirth, less than 1% are actually seen by a community health worker within that time. Exclusive breastfeeding, which we know now is so protective for children, so that's exclusively breastfeeding for the first 6 months of life, which you always imagine must be happening in Africa. They're able to maintain this exclusively only for about 2.5 months or so.
Why?
So part of the reason, yeah, no, those are long. Thank you, Peter. So I think a lot of the stuff that I just told you to start off has to do with it. When you actually, I mean, one of the things we do is we underestimate the amount of time it actually takes for a woman to exclusively breastfeed. And that's both here as well as in Africa. And so, you know, there's different calculations. Women tend to underplay the amount of time it takes to find the space, to get ready, to be at ease, and to actually breastfeed, right? And so different estimates will put it at least 4 hours a day, maybe even up to 6 at the very beginning. Women here, women there struggle to find that time, especially in this situation where many women are alone with home responsibilities. They have a lot of children to care for. They have so many different burdens that it becomes a little bit easier then to add one more serving to the porridge that they're already making, or to give a little bit of fish that's already being cooked to the child. I don't know if Laura has any other things.
No, I mean, I think that when, also when you're in a food insecure area, or you're having to walk long distances for water, it becomes easier to say, I'll leave my child at home with an older child or with a neighbor so that you could do these chores more efficiently. And so many times women are not, you do see them carrying their infants around with them quite a bit, but their preference would be to try and get things done as quick as possible so that they can get back and taking care of their families.
And of all of the interventions in terms of saving lives, both for women and children, most of the evidence would suggest it's that home visit within 48 hours and exclusive breastfeeding that actually pays the greatest, that has the highest yield. Our problem can also be conceptualized in a slightly different way, and that's looking at the poverty, the gender inequality, the tremendous isolation that exists in living in these rural areas, and not particular to Kenya, but definitely present there, is the poor governance structures that exist and the overall lack of accountability. So, yeah.
I'm just curious of the demographics that you're describing. How many of these women are single parents, either widowed or separated, or because the male is working in a distant location?
That's a very good question. Most women will choose to say that they are married because the stigma of being a single woman is so high. And so I've tried to look at what that estimate would be. The one thing you do find is that of the single-headed households that exist, they tend to bear the highest levels of poverty, and then we assume also complications related to pregnancy. But when you look at the registers where women say whether they're married, single, or widowed, everyone is actually married, everyone. But functionally, I'm not sure that marital status translates into a marital status that we would identify as being two people within the home sharing the burden of the household.
Well, then where are the men?
Titus, where are the men?
They're an endangered species.
That's not fair.
And they're not training here at Duke University. They have other responsibilities. And there's been, we could have a whole talk in itself about looking at how changes in the economy and changes especially in land has translated into a loss of position for a lot of men in these areas, which I think is also common to a lot of places. And the kinds of jobs that have come up are not jobs that have been jobs that have actually favored, I think, women's skills more than men, especially in these areas. But for the most part, there are men around, and there are some very good men who you do meet who are trying to not conform, but the reality is that when it comes to the home and the family, it falls on women's shoulders. So with this in mind, we tried to start thinking of slightly different about, a theory of change within maternal newborn health. Because so far, most of our theory of change has been, facility delivery rate is low, we have to get it high. No one comes, or very many people come for prenatal care, but no one shows up later for skilled delivery. We need to, it's always this idea that we have something, it just needs to absolutely expand. So within the social sciences, there has been a different idea about how to conceptualize the problem globally within maternal newborn health, and that's the 3 delays model. Are some of you guys acquainted with that? It's a public health practitioner as well as a lawyer who came up with this. And the idea between the 3 delays model is trying to look at all of these moments in time where there are these delays that then contribute to maternal newborn mortality. And so the first delay is a delay in making the decision to seek care. So it's getting out of the house for the most part. We've supplemented some of them with excerpts from focus group discussions. The second delay is the delay in reaching care. And that oftentimes has to do with the road that you have to take, the transport that you actually need, the costs associated with the season, the time of day. The third, which has been something very important to all of us within the AMPACT consortium because we tend to be clinicians that work in facilities, is the delay in receiving appropriate care. Whether you actually get to see a skilled attendant, whether you get the right drug at the right time, and looking at how many times, even though a woman correctly gets to the facility to deliver, she may not actually get the care that she's supposed to get, and certainly not get it at the right time that she's supposed to get it. So this 3 delays model has been one that has been really useful to structure interventions, because you could say, all right, 1, 2, and 3, I'm going to work on the transport system. All right, you're a delay 2 kind of person, and you might say, you know what, I'm so sick and tired that when people come in, they're being referred, that it takes them 6 hours before they see a consultant or a physician. I'm going to work on delay number 3. And I think the idea is that if all of us just work a little bit on each of these delays, that then somehow things would speed up and people would get the care that they need, and we wouldn't see as high numbers of maternal deaths and newborn deaths. But after about 2 decades of adopting this approach, yeah.
Can you go back to that slide and explain what that excerpt is?
The
next,
The
one
big half the
one
guy
after.
and Missouri's comment.
No, the comment in number 3.
Oh, yeah. So, when you, so Kapsabet is a town that has a district hospital. And Masuriat has a health center, which is slightly lower, and then the home is the home. And so the idea is that usually for the first pregnancy, people tend to be cautious because no one knows really, but once you've proven yourself that you can deliver a baby, then you start going down. And remember, fertility rate in Kenya still stands at about 4 children per woman. In these areas where we work, it's closer to 7. So that's, it becomes the home, it becomes the home, it becomes the home, it becomes the home. And most of it is not just related to like the costs of care, which now under free maternity services, no longer should exist. It's really the kind of treatment and the kind of care that people actually get in the hospital itself.
Are there a lot of trained birth attendants in the area?
So, there's been so many different fads within maternal newborn health that there was a time when the idea was to try and take these traditional birth attendants and reskill them, and then they've become outlawed. Then in the last 10 years, a lot of retired midwives who are in the community have been sought after to provide some community care, and especially in our area, Population Council has been the ones that have carried it out as an intervention as well as like evaluated it as a possibility. For the most part, the government of Kenya maintains you should deliver in a facility by a skilled birth attendant.
Has it been evaluated at all to see if that resurgence of trained birth attendants has had any kind of effect on?
Yeah, so Population Council, when they evaluated it and they looked in Nyanza in a small area, they found that it was very effective. But it hasn't gone beyond. So it's thinking about this approach of time and these delays that in the first few years that we were working together within primary health care, we sort of followed this formula quite well. So we started off, let's train everyone in emergency obstetric care, delay number 3. Let's try and work at community mechanisms or ways to get people referred a little bit faster. The last one was working with community health workers to give them the support necessary and the knowledge to be able to get women out of the home when needed, or triage newborns in the first few days of life. And what we found is that you just keep on feeding the pot from one to another, and nothing seems to really speed up except yourself at trying to cover all of your bases. And that's when we started to think about what about a 4th delay, which is the accountability piece. Can we get to a point or can we start thinking about this delay that exists when communities don't actually recognize their obligations to their mothers and children, where they don't keep the health system accountable, and just trying to think of this way in which to think about the harm that takes place. And so it's not something that fits in nicely as a 4th cube, but the idea is that at each of these points in time that there should be some kind of a check that exists to account for the fact that there should not be a delay in seeking care, that there should not be such a delay for women to actually get to the care they need, and especially within a hospital setting, once you're actually within the facility, there should be a way for the community to keep it accountable to what it actually needs. So that's been the frame of mind within our own group to think about accountability. But thinking about accountability and operationalizing it is quite different. In our community health worker programs, we've made it such that we make them think about the 4 delays as a legitimate concern, and had them, think about, okay, what are some of the reasons why we have these delays in accountability, and what are some of the things that we can do? And invariably it involves involving leadership and power structures within the community itself to move forward. It's with this idea in mind that we actually proposed this to the Saving Lives at Birth. I guess, funding scheme 3 years ago. And this is our colleague Julia Songok, who some of you might know, who is a pediatrician at Moy University. Louis Faison, who's a public health informatics specialist. Myself and Laura, and we were very fortunate to get this initial bit of funding to build on this idea. For those of you who may be hearing about Saving Lives at Birth, it's been this really neat mechanism through which a number of agencies, and now including DFID, have joined to fund innovations in maternal newborn health. And our idea was actually a very simple one. Borrowing, it takes a village, or inahitaji kijiji in Swahili. The idea was to try and find a way to reconnect a community for maternal newborn health. And so in the middle here, we have a woman who's pregnant, carrying her child and obviously something on her head, and her community health worker, and a phone is there. And the idea was to try and create a platform through which the leadership in the community, the chief is up there in the top left corner, was aware of what was going on. There was a pregnant woman, that there was a community group as well of pregnant and breastfeeding women. But there might also be a way for women to be seen together in their prenatal and postnatal care in the facility, and for taxis to be able to stay connected within the system in case emergency transport was needed. So a lot of things wasn't introducing anything new into the system. It was really trying to put these arrows back in place and making sure people were connected. We should have had the people from Uber come along to help us out, because this was the piece that we couldn't quite figure out in our setting at the time. But everything else we've tried to accomplish in the last 3 years. In some sense, looking at community is not so innovative. Over the last 5 to 10 years, there's been a lot within the literature about how to use the community for maternal newborn health, for exclusive breastfeeding, for family planning. Most of the evidence has come from Southeast Asia. And for the most part, what you find is that it's very cost effective. You can definitely demonstrate reductions in newborn deaths, and generally non-significant trends towards decreasing maternal deaths in these areas. So our main interventions through the primary healthcare program has been the Chama Toto, which is what we're talking about today, which is a savings and loans program and a health education platform for pregnant and breastfeeding women. Afia Jami, which is health of the community, which is a group care model for pregnant women that takes place in the facility. And the last one is using community or empowering community health workers with Android phones that have clinical decision support, so that as they're doing their visits within the home, they have the support of the phone to look up someone's medical health records and then guide them through an algorithm care that meets criteria for what they're actually supposed to be doing, and try to elevate the quality of care that's actually being delivered within the home. Today we're going to be talking about the Chamas. So I should also preface this that in some sense, as I said, the Chamas are not entirely new. If you look back historically, they've always been part of the financial landscape of East Africa. They've always been a way for women to come together outside of the home. That's especially in times of famines, anything that starts with the letter F actually, fires, famines, floods, funerals. Whenever there's some sort of a disaster, it's been one way in which women could come together and pool their resources. And so our thinking was, okay, if they're so willing to come together at the time of a funeral, why not try and get them to gather before the funeral actually happens, during pregnancy and during infancy itself. And so that's how we came up with designing a Chama specifically for pregnant and breastfeeding women. At the time that we started this in 2012, we weren't really that strict on the criteria, because we wanted this to be an iterative process with the communities to see like who they would want in their groups. For the most part, we were looking for pregnant women that had a pregnancy less than 6 months, or women who were breastfeeding a child that was also less than 6 months. The groups themselves are about 20 to 25 pregnant women, a little larger than we were expecting. And what we also found is that they really wanted grandmothers or postmenopausal women in the group itself. And so at least 2 were in each of the groups. 2 of our community health workers became the facilitators of each of the groups, but they have a constitution that or a group charter that they have to come up with themselves and elect female officers who have to be women themselves. They cannot be the community health workers. They meet twice a month, and generally the meetings last about 90 minutes, during which the first half they go over, using a very nice job aid, different topics that are either in the medical sector as well as in the social sector. And then they spend the last half of the time in the savings and loans program, where they each have to put in a certain amount of shares for that visit, and they can then decide who's getting the loan that day. Loans come at a cost of 10% of interest that have to be paid back after about a month. And otherwise, there is a social fund, which is like your emergency fund that you could loan from without having to pay back with interest. The topics were some that got generated by focus group discussions with community members, and they range from the importance of prenatal care, postnatal care, going to a facility, to childhood diseases, to signs of TB, and then we've paired them usually with a social topic: how to make a budget, how to speak with your husband, how to keep the peace with your in-laws, how to make your marriage exciting, and also about indoor cooking, as well as kitchen gardening, and a host of other things to try and keep it as broad as possible. So we were very fortunate to have students from Indiana University this summer who traveled out to go see our chamas, and created this video that we've been using. So it's about 3 minutes, and probably it gives you a good sense from Bunyala what's the look and feel of these chamas actually are.
Somo ka afya usomyange ba mama barimo kwaka buhane kwaka family planning kwaka immunization kwaka breastfeeding kulunya bana kwaka chaka clinic hare nakulochi mborula ba mama bano bachako bamusyamo kulochi mboinamba ichireho ngeza kamwe yaba mama bari kuchanga msibitali ana kunyola ko kumecho. Hapo lambo siama semester ni faida yako kabisa kugula wa bana rukom.
Nabula muna bana kulo bera kama haren ganda yaranga ina mubana bambere sinda janga clinic mapema ayo mwana sinda nuniyange myosi sasa ayo mwana uchopima nda pimwana ni afundwanga sinda ni kama chine hani ndapaka mwosi kwa tisa ninja kama hali simupima niyo cha clinic sinda janga nare lakini ndo hana ndesia manga mabarue kesia mafunzo kumsiama karue kesi ulai ndo lambo mwana ange ni mununi myosi sasa arinenda mwana umama madwe mangi mwana abanenda afya akula bila madegere, hakuna mambo ya kuharahara, mtoto anakuwa hata kula hapa na hapa.
Kesi yako karwe ikia anabaraga bekesi bwako bya bechango ruikia mbulwa bahana babali bali muskanda sinobasi abasiri mu group yo kuyinda kola abanyanda kuminya kola abanyanda kwelinda abondo amalwa ekataka maleli kola abanyanda okaribisha basacha babwe bekesi na mali.
Pasaka mesie na kuwa mchiu nyama kabisa. nahitaji kuona nao nisaidie.
Na afya yao pia imekuwa nzuri.
Siama nina musiku mwenyere muno.
First, I'd like to thank two medical students, Wyatt and Zach, who were in Eldoret, Kenya this summer, first-year medical students who come for a 2-month period who helped put this video together for us. So none of us have a multimedia. We've learned on the job in our multimedia and our research skills. So we were really grateful for them. I want to take a moment to pause to see what questions you all have about how chamas are set up, because next I want to get into our outcomes and what we saw after implementing our chamas. Any questions?
I'm especially interested in to what extent you think the microfinancing aspect is really driving participation as opposed to other components of what's covered in the chama.
That's a wonderful question, and we actually, when we first thought this up, we did not have the microfinance component, and we realized that really it could add a lot of glue in keeping women together and keeping them coming back. And so I'll talk about the outcomes of the microfinance component and what we've seen by it. But my just honest opinion is that it's really a motivating factor in keeping them a part of it. But when they talk about what they got out of it, it's less about the money and more about the respect that they gained from the money, from being able to start businesses or being able to use that money to go to the facility. Many women talked about how it improved their relationships because they didn't have to ask their partners for the money. And in general, I think we all now believe you can't have chamas I'm not sure if we had it up there, but it's like chai without sugar. So tea without sugar. You can't have chamas without the health component, and you can't have it without the microfinance component. Because really both pieces are key to empowering women when it comes to their health and their children. Yeah.
Just sort of a follow-up, and you might get to this, so I apologize, but what was I guess each time you had these meetings, like what percentage of the 20 or so women would show up? Would it be almost all of them, or would it be?
The meetings were very flexible. Women are charged a fee for being late or not showing up. It's a small fee. What do you remember?
20 shillings.
20 shillings, so about 40 cents, and my math is not good, but 30 cents. What we were finding is that the majority of women do show up for them, but there is a dropout rate. So we did have women that came initially and then decided that they did not want to be in the chamas. And we're still analyzing all those women, the women that didn't commit and participate. We haven't fully gotten to that secondary analysis to look at those women. Do you have anything to add? Any other questions about just how the structure of chamas or what they do? One thing that is important is that in addition to the health education piece and the savings and loan piece, we also ask women at some point during the chama as a group to commit to goals together. And so each chama chose what their goals were, but that could have been exclusive breastfeeding, or that could have been getting to the facility for A&C visits or delivery. We did not facilitate that choice at all. They identified their problems within their community for maternal and infant health and then decided upon those themselves. So what we found, we had 400 women join total, and this is the mentors, the elderly women, this is breastfeeding women, and pregnant women. 222 of those were pregnant, and we started 16 groups in the 16 community units, so one group per community unit, with 32 CHWs leading, so two per group. First, I'm going to talk about how this improved health, and specifically, a lot of the indicators we captured were the uptake of services in facilities, and not so much the end outcomes of mortality, because as you can see, our sample sizes are quite small to be able to capture mortality. I can't talk about the numbers we did get, but they're not statistically significant. And then second, about what we're really interested in, does this spread? You have this Chama of women, and does this spread throughout the community? And does that accountability women learn just in managing money and pledging together to improve things within their group, does that spread to accountability throughout the community and then upwards to the facility? I think you had your hand raised.
I did, but I'll wait.
Oh. And then finally, can we sustain this? And I think that's anytime you're thinking about public health or global development, is you can get something started, but how to keep that momentum going and how to keep it financially sustainable, not just people motivated to continue it. So first, looking at our health indicators. So what we did was a retrospective cohort study. The three main team members were missing one of our sisters and colleagues. Julia Slongok is a Kenyan pediatrician. We all kind of went into this with like the women and the infants at heart and designing a project we thought would meet their needs. And our research study kind of came secondary. So we were very much doing implementation science. It is not a controlled situation, but we did our best to find a good matched control group. And so we took women who presented first ANC at facilities. 90% to 95% of women go to one ANC visit at the facility. So we did miss 5% of women who don't ever show up at a facility, who are the most high-risk women. And then we did a retrospective interview for each of those women to ask about their pregnancies and the uptake of their commitment to services at the facilities. And so, as you can see here, our control group, if we look at first 4 ANC visits, we went up from 37% to 64%. And these control group numbers will vary from the ones Astrid said in the beginning of the slide, because the numbers she gave you were before we ever implemented any primary healthcare activity within AMPATH. So you can see that we're improving everything through our AMPATH primary healthcare activities, but then we were trying to look at just what did this group do outside of those other projects where we were working on improving supplies in the facilities, improving training of facility providers around emergencies for maternal and newborn health. Deliveries went from 50 to 84%. And one I should mention specifically, if you really look at what is the most effective way to improve maternal and newborn mortality, one of those is making sure you get a visit in the first 48 hours, either in the home or getting that woman to a facility, but usually we think about that in the home. And she had put a measurement of 3% up. The primary health care program, we think, and any other program operating in the area had brought that in the 2 years up to 38%, and then our Chama's looking at the control group, it was 76%. And then finally, the EBF stands for exclusive breastfeeding to 6 months. Our control group was 47%, and our Chama's were 82%. So we were hugely impressed and very happy with these results. They were all statistically significant, but it still leaves you with a lot of questions if you're a scientist and a researcher. But any questions about health outcomes?
Did you compare the pregnancy during which they participated in the Chama to their previous pregnancies? Because I'm just thinking about one of the interviews in the video was talking about how sort of previous pregnancies it had been different than now that she's participating in a Chama. Her health behaviors are different.
We did. We looked at had she delivered in a health facility before. We didn't look at breastfeeding rates or ANC visits. In trying to capture data going home to home and asking women to recall retrospectively, the data you collect is really variable in quality. So we were even struggling just looking back at the most recent pregnancy. And so to go back 2 pregnancies, we knew that we wouldn't even be able to trust that data. And so we asked, did she deliver in a facility before? And I can't remember off the top of my head. Both groups were equal. We didn't get a biased sampling of women that had already delivered in facilities. But I want to say it was around 40%, 30-40%. maybe even lower. I can look on my computer.
Were
right
most
after
of the
this.
women in the group, was it not their first pregnancy? Or
Yes.
did you have many that were sort of there?
We had a
during the
mix.
first
We had a mix, and we
pregnancy?
have all that data, but most women had had a previous infant. So, and I need to look up all that data. I should have had it on the tip of my tongue, but we haven't done a full analysis of that. So we've done our preliminary analysis.
I'm curious about the control group, and I apologize if you said this already, but and the penetration of women participating in the Chamas from a given community. So for instance, were your controls from different communities? Because I would imagine that if they're in geographic proximity, whether they're actually participating in the Chama or not, they may be influenced somewhat by other women around them.
That's a great question. So we matched them at the facility. So we did facility matching, group matching, and so we looked at each of our facilities, the 8 facilities in the region of the 16 community units, and we looked at what does this group of women look like coming to this facility, and we matched them to that same facility, the women that came to ANC at that facility, to look like that other group. And so so it should be pretty similar as far as location and where these women live. Women they are smart when it comes to their healthcare. So they do, if they hear about a provider that's much further away that they've heard is better, they will travel to find that woman. So, but for the most part, we try to account for that and try to keep them in the same area. Yes?
This might sound garbled, and I'm still kind of
No
formulating
worries.
this question. But harkening back to what we were talking about earlier with the reason that people weren't exclusively breastfeeding, did you look at any associations with how like income changed over time, with how exclusive breastfeeding changed over time, so how the impact of like microfinance and breastfeeding may have changed? Because it's pretty dramatic, the control and your intervention, 47 and 82%. So I'm wondering, like, clearly gender inequality couldn't change that dramatically because of Chama in that time, but maybe the income did, and so maybe they weren't having to leave their kid for that period of time. Do you understand what I'm saying?
Yeah, I do understand.
I'm wondering if you were able actually to kind of disentangle that within the data at all.
I think that we will be able to, once we get a biostatistician on board and really do a good secondary analysis, we'll be able to look at associations similar to that. We did not go in our interview and ask their average income before and after the intervention, so we won't have that specific, but we'll be able to ask their, look at the current monthly income generation and kind of dig into that a bit more. But there's a lot of questions with that exclusive breastfeeding, because certainly the women in the Chamas learn that they should be breastfeeding exclusively till 6 months. They've committed to it. And so when they answer, yes, I've done it, have they done it? Or breastfeeding is a hard one to capture because everyone knows what you want to hear if they've been educated. But that alone shows a change. At least they know what is wanted. That is a behavior change in and of itself. They have the knowledge to know what the desired outcome is. Any other questions about health? So I touched a little bit on mortality, and we can't at all look at our maternal mortality ratio or infant mortality, but just looking at it when you're thinking like a provider like me, and I'm only just learning the science side of it, or the research side of it, we did have half the number of deaths in the Chama group as we did in the control group. And so both newborn mortalities and the maternal, there were 2 maternal mortalities, I think, in the control group and 1 in the Chama group, and then of infants, I think it was, I want to say 10 and then 5, but I can double check. But so it leaves you wondering, like, you want to see it at a larger scale and see what happens. So next, that question of does this leak out into the community? How much do women who are not in Chamas benefit from this, and we did a series of focus group discussions between women who were not in Chamas, and then we did focus group discussions from the Chama women. And every non-Chama woman in these focus groups knew about the Chamas. There wasn't one that we had to kind of explain what this was, or in the same way that focus groups that we used in other areas, we'd have to explain what a CHW was to try and get them to understand what we wanted to evaluate. These women knew what a Chama was. They also, many of them had said that they they were nervous or skeptical about Chamas at first. Either the finance piece scared them, or they just weren't sure they wanted to be a part of it. But there was a lot of regret in those women who had decided not to join a Chama, and they all committed to, like, when Chamas come back next year, I'm in. And so that there was definitely a leak within our qualitative research into the community. And then, as you can see with this quote, women are even bringing that peer support that they feel within the Chama. They're bringing that to the women that are in their neighborhoods. So. All right, and so for the microfinance or savings and loan piece, so the way these groups run is a bit complicated and takes some time. So if you're interested, just find us afterwards, and I'll go into how this works. But essentially, women every time they come, they give a share price. They can give 4 shares, they can give 1 share, but they have to at least give 1 if they've committed to being in the GISE, which is the savings and loan group. And then they can take a loan that accrues interest if they need some money, and then they pay back that loan as they are able throughout the year. But the interesting thing about these groups is that at that year mark, it disbands. The Chama disbands, the savings and loan piece disbands, and they all receive the share, the percentage share that they had put in, plus profit. And so women, if we had a group of 30, they'd receive about $20 by the end, but only a small percentage is actually interest or profit that they earned. Mostly it's a savings program. And if you've been to Kenya, or if Titus can tell you, I'm sure even living in the US, if you have money in your pockets, it's quickly in someone's hand, because there is so much need, and the stories you hear, you can't say, no, I'm keeping this money in my pocket. And a sister is not someone who's an immediate relative. A sister can be 3 degrees away, and you're still accountable to making sure that your community, in a financial way, if you have something, you need to give it out. And so this really allows women to have a savings where they're not constantly using that money for the school fee or the small things each day, the husband asking for money or whatever, wherever money it just disintegrates, really. So wherever it goes. The women really enjoyed at the end, and we give it right in November, December as they're getting into the holidays and really want to have some spending money. And so this gave them that. And so really when we looked at the qualitative research for what did the finance piece do, many women started small businesses, and then many used it as a way to get themselves to the facilities, whether it be transport or paying the fees at the facilities or using it for medications. And so really they felt that this money had been useful in many different ways and in their relationship with their partners.
What was the loan repayment like? What was the loan repayment rate? What proportion?
What percentage or what
proportion
who
who took out a loan repaid on time, or did you have many defaults?
No, in general, this system is one that's used across our AMPAC programs, and whether it's women or men, doesn't seem to make a difference. The loan repayment is above 90%, regardless of the groups.
How much is a share loan?
Our shares, the groups chose them themselves. And so most were around 50 shillings. Some of the groups started at like 150 and then decided, oh, we've been too ambitious because we have to come twice a month with this 50 shillings. And somewhere as low as 25.
So I was trying to understand the difference between savings and insurance. This is not an insurance scheme because they get the money back. It's okay. So is there talk about the concept of insurance and risk here, or is that just a different conversation?
We have very close colleagues who actually in the same area have implemented an insurance program within this area called Zuri Health. And they've just implemented it in the last couple of months, but which would be more your typical insurance scheme where the community's payments are going to pay for the health of the community for services. But maternal and newborn health is supposed to be free. Now corruption is a problem, and so there are oftentimes informal requests for payments, but maternal and newborn services, children under 5 should get free care.
And so that, the way it's sold is not that they buy into this for healthcare needs, it's for it's like other health-related needs, like you said, transportation to the hospital, or is it sold primarily as, so I'm trying to understand the difference, the relationship between the maternal and child health care itself, services, and the savings plan.
Yep.
Savings plan can be used for something totally different.
It can.
Does it have anything to do with?
They were completely, I mean, we kept them, there was a slot of time for health, education, social education, and then a slot for savings and loan. And you could join the Chama without joining the savings and loan if you didn't feel like you're financially able, but you wanted the peer support and you wanted the health education. You did not have to be in the savings and loan program. And it was not tied to that you must use this for health purposes. It was open, it's a savings and loan, it's like a bank for you. The social fund is the one piece that you don't have to pay back for profit, and the group could vote on to say, you know, our friend had a complication in pregnancy, had to go for C-section, and she's really stuck and can't get back. Do we want to use our social fund to get her transported back? Or at funerals, you often make contributions for weddings.
Can you talk through the rationale for disbanding the financial piece at the end of every year, as opposed to if somebody wanted to leave the group paying them out, but for people who wanted like longer term savings?
Yeah, it's how MPATH has done it, and I believe based on literature, but it basically ask for a commitment from people to really like make sure that they're going to come to these groups twice a month and really commit to this being important. And so they decide on a constitution. Now, could they decide as every 6-month disbandment? And they can within their constitution, but the general has been 1 year, and that's kind of what we recommended, and every group did it. So
it's also to allow for election of new officers.
Okay.
So it creates some kind of renewal. The surprise that we got was that after that year, groups they grouped together again. And that's what Laura will just talk a little bit about is what to do. Because we started off with year 1 in terms of the focus, and then quickly had to make up a year 2 plan because the groups decided to meet again. And so even though it wasn't within our funding scheme, it didn't matter because we didn't have to put any more money towards it. All it was providing some guidance to the community health workers as to what they could focus year 2 on. Which has been on positive parenting skills and focusing on complementary feeding practices.
Yeah, so I think Astrid led into it very well, but I think we're currently in the process of trying to say what do we need to incorporate in that second year. We focused very much on breastfeeding, on family planning within that first year. On making sure they were receiving health care, but now we need to refocus on what does the care a woman needs postnatally, like 6 to 12 months postnatally, and looking at children that are no longer infants, but now are 2-year-olds and 3-year-olds. So I think that's where we wanted to kind of see what you guys thought and see what ideas you had in thinking about that second year. We can just kind of talk about as we scale up the problem. Yep.
I wonder, it sounds like you've done a lot of focus groups, which is great. I wonder, have you done any asking how men are perceiving the Chamas and just how I'm just curious how that's been integrated, how they integrate into the community.
So we We did see in some community units possibly 2 or 3 men or husbands who actually beat their wives for joining the Chama. Very fortunately, when we started this, we started with the administrative leaders, which are the chiefs in these neighborhoods, and they're the ones who dealt with those situations quite swiftly, so that for the most part, women joined without hesitation, and especially once they saw what the Chamas were doing, most men actually were trying to encourage their wives to get in. So nearly all of the chiefs have their wives in one of our groups. That helps. And we weren't able to do or I guess just focus on men in our focus groups. We did have focus groups with health leaders and other administrators who tended to be men. And for the most part, there was a lot of support because it was an opportunity for women to be able to gain more money into the home. And so for the most part, that's what people are looking for, is avenues and access to capital. Even though people have like phones that can transfer money, it's actually very hard to get capital in your hands and to be able to actually use that as a platform for a loan. And so they were, I think, thrilled that there was just like another opportunity for the family.
Great. So when we talk about scaling up, we want to kind of scale up the program within just the program design, but also scale it up so that it can be on a much larger scale. And as we do that, I think Asha did a great summary of how we want to focus on accountability, determine whether we can improve governance within communities and within health facilities with these Chamas. And so that's one area we haven't really honed in on. Over time, can we improve accountability within a facility by giving a woman the education to know what she needs on arrival to that facility? Can she then hold her health providers accountable to give her that care? And so that's, I think, really our next step. Once we can get these going, can we actually see a cultural shift to improve accountability and decrease corruption, which is really always holding the public health care system back in Kenya and has a huge effect on health, but is very difficult to study. In addition, I think looking at how this improves relationships within the home for both children and women. There is a lot of violence in homes that is considered not necessarily acceptable, but you don't want to draw attention to it, and people don't seek help when they're suffering from abuse in their homes, and trying to decrease all the different stresses that families deal with in Western Kenya. And so I think much of what we're trying to do right now is brainstorm on where we're going with Chamas, and trying to see how we can incorporate early childhood development into our Chamas. There's more and more literature in the U.S. And abroad about how important early childhood development is. And I don't know if you've been on the pediatric wards much, but it is incredible. People walk through and they're like, oh, it's quiet for a pediatric ward. Babies are so good here. But I always find myself asking, is that because we're failing to interact with our infants and like improve their development, or are we encouraging more passive behavior by women not having that education to realize that reading, singing, and they're struggling with finding the time to do that. Certainly women love their children. I'm not saying that they're poor parents, but parenting skills, it's not necessarily common sense, and positive parenting actually takes a lot of education for people to understand what that means. And so just to end up, this is our Chama in Kenya. Our team is incredibly important to us, and so we do everything as a team. As you see, it couldn't be Astrid alone or myself alone up here. We have to have at least one of us wherever we go. And so this is our team in Kenya. We were thankful enough last week to have Julia Songok visiting us here in the U.S. We were in D.C. together, and so and Asha will be heading back there in 3 weeks. So, any other questions? All right.
Thanks,
well,
Lauren.
thank you so much.